It's just 8:01. We are delighted to have Dr. Matt Luther from Vanderbilt, who will be talking about MR antagonism in treatment for proteinuric kidney disease. Dr. Luther is an associate professor of medicine and clinical pharmacology at Vanderbilt, where he did, I think, all his education, including a master's in clinical investigation. He's the director of their comprehensive hypertension center as well. He served on several councils at the American Heart Association and the American Society of Nephrology. He's got over 75 peer-reviewed publications. And he's the aldosterone expert that I know of. So go ahead, Matt.
All right, thank you, Swapnil. So today I'd just like to cover the background, rationale, and some of the, I'm not going to do too much basic science, but talk a little bit about MR antagonist, aldosterone and MR antagonism for diabetic kidney disease specifically. From what I understand, with Greg Hundemer there, you get lots of specific talks about aldosterone, spironolactone for resistant hypertension. I'm not even going to talk about that today. So I'm going to focus specifically on proteinuric kidney disease, diabetic kidney disease, and some of the newer agents that we've got to use for that. So classically, you may or may not have heard this. I'm sure you've heard the classic part that aldosterone activates the mineralocorticoid receptor in epithelial tissues in the kidney, which provokes sodium retention, potassium excretion, and under inappropriate conditions, this leads to volume expansion and hypertension. So this is the classic picture. Over time, we've learned that there's mineralocorticoid receptor in other tissues besides the kidney. They're throughout the body. And you can have pathologic effects in these tissues in the heart, the vasculature, and kidney tissues that are non-epithelial tissues. And under inappropriate conditions, aldosterone activating the MR provokes cardiac fibrosis, especially perivascular inflammation and glomerular injury, either directly or through this secondary to the hypertension, which it also causes. So just a few slides on the basic science background on this. If you just, these are some of the first slides that really convince people that aldosterone kind of has a direct effect in the heart or the kidney. So if you just give aldosterone alone to rats, then you provoke this fibrosis in the kidney, glomerular damage, and inflammatory cell infiltration. One interesting thing about all the animal models that you'll see with aldosterone, if you just give aldosterone alone, you really don't see this injury. It really takes aldosterone plus sodium chloride, so you have to give either salt in the food or some people give it salt in the drinking water. So it's whenever people say aldosterone administration, they typically mean aldosterone plus salt. And when I say, I mentioned on the previous slide, inappropriate aldosterone, I'm largely talking about administration or endogenous aldosterone in the setting of excess sodium intake or salt. If you give a eplerenone to those same animals, you basically block all this injury. So it's a specific MR mediated effect in the rat. And you see the same thing in the heart. So if you give aldosterone plus salt, you get this injury in the heart, you get macrophage infiltration, and if you give a eplerenone, you block this. So this has been, and this is just a little bit of the basic research. There's plenty of other models where they do this as well. And we became interested in whether, I told Swap I'm not going to cover the aldose synthase inhibitors, but I did studies in these aldosterone synthase deficient mice, and we became interested in, okay, some of these traditional models that use angiotensin II to provoke glomerular injury or cardiac damage, how much of that is how much of that injury is responsible and mediated through aldosterone and the MR. So if you give these mice, these are mice that we did not do nephrectomy or anything, it's just angiotensin II plus salt in the drinking water, you get, this is heart tissue, and the vascular inflammation that you get and fibrosis that you get around this, so perivascular inflammation, is really profound. They get hypertensive as well, of course. And if you give them spironolactone in the chow, you can block most of this, maybe not all of it, but most of this perivascular inflammation you can block. And in the mice that are unable to make aldosterone, so they're aldosterone synthase deficient mice, that alone will block most of the angiotensin II induced injury, so the perivascular inflammation. And if you give these, surprisingly, I thought this was a nice trial design where we gave spironolactone in addition to aldose synthase deficiency. Unfortunately, most of the injury was prevented already, so there was not really the ability to show that in addition to that you could block more injury with the MR antagonist. But I think that's another interesting thing to look at. And there was some signal in the kidney with albuminuria, but again, not significant. So the conclusion of this is much of the injury that's caused by angiotensin II excess is actually not just, traditionally we use an ARB. You could even block further downstream from that and prevent some, but not all the injury. And this is, like I said, just one study. Other studies also support this. Going into the other tissues that express the MR, Iris Jaffe, who's at Tufts, has done a lot of studies in the vascular smooth muscle, and actually I think this is in all smooth muscle. So if she took all these different tissues that also have smooth muscle, you can identify the MR in most of these tissues. And if you give them, this is a smooth muscle specific CRE, you can see that in the uterus, the colon, the bladder, the aorta, and the carotid, you get you could split or you excise the MR in these tissues. So it's present there. She's really just interested in the vascular smooth muscle. So when she took the aorta, you can see that when she stripped the endothelium, it really gets rid of most of the band. So what this means is that most of that MR is present in the vascular smooth muscle in the aorta, and she basically excised it with this system. And with aging or Ang2 infusion, she's got a number of pretty elegant studies which show that this prevents the hypertension in response to Ang2. Also, some of the newer studies look at just aging and the role of vascular smooth muscle MR in aging, and it looks like those mice are protected from that. So just to sum up on that, it's vascular smooth muscle MR is important also for other vascular damage. I did a recent review with Agnes Fogo on the role of the mineralocorticoid receptor in the tissues in the kidney and how this may provoke fibrosis. It's more of a kind of theoretical discussion, but there's more MR in all these different tissues. A lot of the injury that we see is mediated through the hypertension, which I believe is mostly driven, not all, but much of it is driven through the sodium reabsorption in the kidney. But there's also direct injury in the mineralocorticoid receptor in other tissues and the other cell types within the kidney, such as podocyte, mesangial cells. It's in endothelial cells. So it's in multiple cells throughout the kidney. And how much that contributes to this injury and what percentage-wise it's responsible for this remains to be definitively shown. Like I said, much of it is through hypertension, but there's also MR in the macrophages. I think this is a huge area where MR activation in inflammatory cells, the lymphocytes, macrophages, likely provokes or promotes the inflammation and fibrosis within these different target organs. So if you'd like, there's other supplements, other issues, manuscripts in this supplement, which also kind of discuss this as Finerenone has come on the scene. They're interested in this basic science and getting some of this stuff out there. The other one to read in this article too is Frederick Jaser, who's in Paris, who's done a lot of work in addition to Iris Jaffe on the non-renal mineralocorticoid receptor. So if you read anyone besides our article, read Frederick's paper as well. So I'll go into the MR antagonist that we have available. Everybody knows about Spironolactone. That's been around for years. But I like to tell people or remind people that progesterone is nature's MR antagonist. So progesterone is actually fairly potent antagonist at the MR. Usually we don't reach physiologic levels, especially in men, but it is an antagonist in men, with the exception of that really kind of rare and outlier MR mutation, hypertension in pregnancy, where progesterone does serve as an agonist. And so does spironolactone and eplerenone, by the way. But typically you don't worry about that. That's, I'll probably never see a case of that. You probably won't either. So I don't worry about that either. Spironolactone is similarly potent at the MR, molar-wise, but it also has these off-target effects, which lead to most of the problems we run into. So spironolactone antagonizes the androgen receptor. At really supratherapeutic doses has an effect on the glucocorticoid receptor, which we really don't see too much of that, I don't believe. But we do run into issues with the progesterone receptor where instead of being an antagonist, it's an agonist. So it has some progesterone effects, which leads to the gynecomastia and some of these off-target effects. The androgen receptor effect probably contributes to some of the sexual dysfunction and possibly dysmenorrhea. I've never really seen a whole lot of dysmenorrhea in women, but it's a potential side effect with the progesterone as well. Eplerenone on a molar basis is less potent, and this, I think, in my hands, it translates clinically so that you see less of an effect clinically from eplerenone versus spironolactone, which is a pretty potent antagonist for hypertension. And of course, eplerenone, the benefit of that is it has less off-target effect at the androgen receptor or the progesterone receptor. So the really interesting area, and I first learned of this when somebody asked me to write a review in the current hypertension or something like that about non-steroidal MR antagonists. And I'd seen some of the work at one of the ALDO conferences I go to, which, by the way, is in Chicago this year at the International Aldosterone Conference. I meant to put a slide in there. If you're interested in research in this area, send an abstract to that and go to it. It's an excellent small conference, about 100 to 150 people, but they're all the top people in the field. So you should go to that if you're interested in aldosterone. So I looked in the patent review and some of the early literature on this, and it's really a fascinating field about how these MR antagonists were discovered. It was discovered in a high throughput screen where they were looking for any compound besides what we had already. And they identified some targets, and some of the top targets were calcium channel blockers. So amlodipine being one of them, amlodipine, nimodipine, felodipine. So these, you can see this looks like nimodipine and felodipine look like they're almost as good as eplerenone. Amlodipine is not quite as good, but it has some effect at really high dose. So they initially thought that was kind of an outlier, not really something that would be useful. But as they looked at some of these different compounds, nimodipine, felodipine, nifedipine, they did modify these compounds to increase the potency, and that's where we got to the non-steroidal MR antagonist. So I'm just going to show you the structural similarities. I'm not a medicinal chemist or anything like that. So anything that I'm showing here is just kind of, hey, look at how similar the structure. So the backbone of finerenone is to nifedipine. You stick something up here, you complete this right here, and it's basically turns nifedipine into finerenone. So that is not just an accident. That's actually how these compounds were discovered. And then they were improved upon by taking the lead compound, modifying them, and leading to potent and specific antagonists that are non-steroidal. So this is also important because steroids are hard to synthesize chemically. It's really hard to mess with some of these things. And obviously you have the potential for more off-target effects like spironolactone. So this compound, BA948862, became eventually Phener when they got a name for it. And it's a specific antagonist. This is looking at physiologic markers, so the urinary sodium to potassium ratio. So it's pretty potent at higher doses. It seems to have a higher ceiling than a Eplerenone does for this, actually. So it's potent, and in other studies, they show that it's specific. So I showed the table with some of the MR antagonist potencies. They show that it has no effect on progesterone, androgen, glucocorticoid, or ER. And really none of the other compounds. So they do this all in the drug development. There's a number of other compounds, and this is now an incomplete list. There are some other ones that have come down the pike as well and are in development. So Phener is just the first. In Japan, I believe they have Hexaxerinone already, which has been around for a little bit longer. So I don't have that on there. So that's an incomplete list. There are some more updated ones. All right, so why are we interested in some of these newer compounds besides just for these companies to make money, which of course is the primary interest for them, but it can also help us to have more compounds to get around specifically some of the side effects we see with spironolactone. So I love spironolactone. I use it a ton. I have trouble recruiting for these trials that have exclusion criteria for anybody on spironolactone because almost all my people with resistant hypertension are on spironolactone. So I use it a ton. I use Eplerenone in places where I can't or people prefer to use it. So spironolactone is really potent. Everything Greg Hundemer's told you about it is true. It's fabulous for resistant hypertension, and it has recently, I think everybody's realized that. And so now they're using it, and it makes my life more difficult when they send people to me already on spironolactone. So I've already got one trick in my bag that's kind of somebody else has already pulled it out. It does have side effects that are dose limiting. Already mentioned the gynecomastia. I still use it. Rarely you have that be a huge issue. And if you do have to educate people ahead of time, or else they don't have any clue why they're developing this strange problem in men. Impotence is also an issue. So Eplerenone and spironolactone share some common side effects, hyperkalemia being the huge one. And I'll go into more detail down the line with that. But obviously that's a huge issue. And the biggest issue, I think, the decline in renal function is less pronounced. I've never seen just huge, acute kidney injury with the spironolactone when starting that cautiously and monitoring closely, but it does cause a reversible decline in renal function, and I'll show some examples of that in the studies as well. And people don't think of spironolactone with hyponatremia, but it is an issue, or it can be an issue, and so you do have to consider it. I try to ignore it, and most people don't know about it, and so I'm able to ignore it because most other people don't think about this too much. But in people who, you remove everything else and they still have some hyponatremia and you've got to do something to adjust it, it can also contribute to that a little bit. I think also, by the way, the aldosynthase inhibitors, I think the hyponatremia may be a little bit more of an issue with that. We'll have to see as it gets into larger studies. So just like the thiazides, but not as much as the thiazides. I mean, obviously, we use thiazides a ton. It causes a ton of hyponatremia. I don't think either of these drug classes are nearly as offensive as far as hyponatremia as these others. And of course, in our patients with diabetic kidney disease or severe heart failure, we probably aren't primarily taking care of all these people with severe heart failure, but all of our patients to some degree probably have some chronic kidney disease or diabetes, and they have an increased risk of these side effects. And one Canadian has shown this, and I'm sure you've seen these studies. So David Gerlink has shown that after RALS, which was the heart failure trial, came out and convinced everybody you should be using Sperolactone, the hyperkalemia admissions increased dramatically in his chart reviews or his study here. And I believe that's obviously a risk. When you go from a clinical trial to a real world setting, you don't have the inclusion criteria, the monitoring. So just a reminder that you do have to keep a close eye on these people and select your patients carefully. All right, so now I'm going to go into the proteinuric kidney disease, and this is not diabetic. This is just all proteinuric kidney disease. This is the first kind of report that kind of convinced people, hey, this might be a good idea. It was actually just a letter to the editor in New England Journal. And it's an uncontrolled study, but it's looking at people with persistent proteinuria despite being on an adequate dose of ACE inhibitor. So 2001, when this was reported, so this is obviously done before that, we really didn't have anything besides ACE inhibitors that showed a reduction in proteinuria in these conditions. So these people had pretty significant proteinuria that needed some other treatment. And so we were looking for anything. They gave Spironolactone for 25 milligrams a day for 4 weeks, and it had a really pretty pronounced decrease in a lot of these people with pretty refractory proteinuria. But it's not controlled. There's no follow-up after you take them off. So anyway, this is just kind of a first report. Just like those first reports in resistant hypertension showed a 20 millimeter mercury of drop in blood pressure. Nobody really believed it was that great until people did really well-controlled studies. And it's really not 20 millimeters on average. It's more like 10 to 12, which is still really impressive. So other studies came along, and the next one that really kind of pointed that this might be effective is looking at people with aldosterone escape. Now, this is not going to go too much into all the terminology, but in this paper, they're talking about in people that you start an ACE inhibitor, you should get a drop in serum aldosterone concentrations. They looked at people who had aldosterone escape or increase above what it was at baseline, even though you started an ACE inhibitor. So this is not what I really prefer to call aldosterone escape, but they're talking about those people who had high serum aldosterone despite the use of an ACE inhibitor. And the people who were in that category had obviously higher aldosterone concentration on the left. Their renin activity was actually no different. So there's some independent aldosterone excretion that's not Ang2 dependent. But the more interesting finding is that they had more proteinuria. They had more, this is urine albumin excretion. So they found this in 40% of people. And a lot of these people had, this was in people with diabetic nephropathy. So they added Spironolactone 25 milligrams for 24 weeks in this case. And they noted that really in these people, there was no change in blood pressure or with potassium. I'm sure, I think most people probably will see a little bit of a change there. But they saw a decrease, and this is a pretty low grade albuminuria, but you did see a significant decrease in the people treated after that with Spironolactone. So again, not a controlled study. There's no placebo. It's not really a randomized clinical trial. This is just an observation. But this is 2003, so this is still early in the time period where we don't have much evidence there. And then really, this is the first one that it's not still a placebo-controlled study, but it convinced me a little bit more that, hey, this is a treatment that's likely to reduce proteinuria. So this is the group led, first author is Bianchi. So they took these people with persistent proteinuria, and you can see this is 3, 4, 5 grams per day in some people, so really high-grade proteinuria in some people that persisted despite adequate ACE inhibitor treatment. And at 2 weeks, there was a significant reduction in a lot of these people that continued to get a little bit lower at 8 weeks. But the more convincing thing that it's providing this benefit is that you withdraw spironolactone and proteinuria rebounds. It goes right back to maybe not quite where it was, but it definitely increases after you stop spironolactone. And the people who got the largest benefit were those who had higher aldosterone when you started the study. So they not looking at renin or anything like that, but just aldosterone. So still not controlled, but more convincing to me at least. And then we start to get, actually the same group does a little bit more of a better comparison. So Bianchi and colleagues took these same groups of patients with proteinuric kidney disease and reasonable GFR, so average of 60, but they had significant proteinuria, 2 grams a day, fairly normal potassium. And importantly, most of these people were either on an ACE inhibitor or an ARB. So most of these studies are add-on therapy to traditional treatment. And this time they had a comparator group that's a little bit better than what we've had before. So they had a conventional treatment arm and compared this to the people that were put on spironolactone. So I mentioned that spironolactone drops GFR quickly. So within the first month, you see a drop in GFR in this red or spironolactone group, and then it kind of stabilizes. We're used to, as nephrologists, we're used to seeing this. ACE inhibitors, ARBs, now Sglt2 inhibitors do this. All these drugs that are beneficial for kidney disease show this initial drop in GFR or increase in creatinine, which I'm just showing it as estimated GFR. In a conventional group, you see more of a persistent decline in GFR. And of course, as you'd expect in the spironolactone group, you see an increase in potassium. So this is a pretty pronounced increase in potassium in this group. So 4.3 up to 4.9 or even higher. So this is showing that it's working, it's doing what we're wanting it to do, but obviously we've got to watch this. And the conventional group really didn't see any change in potassium. And the most pronounced part of this is that proteinuria, focused on the left panel first, proteinuria decreased tremendously in the spironolactone group, but in the conventional treatment arm, there was really no change. So this is true. It held true in people with a low GFR, less than 60. This was not advanced kidney disease, but just less than 60 or greater than 60, if you cut it that way, there's really no difference. It's people benefited from this treatment. All right, so spironolactone, hopefully I've convinced you that spironolactone, MR antagonist with spironolactone, reduces proteinuria and albuminuria. None of these are placebo-controlled trials, so this you can argue with that. And also, more importantly, none of these studies are showing a prevention of progression to end-stage kidney disease or even some surrogate marker of progression. But unless you're really convinced about the proteinuria. So they definitely reduce proteinuria. So the next maybe better controlled groups of studies were done with eplerenone, which at the time was still being kind of actively developed for heart failure. And that's really kind of the heart failure in post-acute MI. And there were groups, Gordon Williams and Murray Epstein, part of this, that were looking at eplerenone in diabetic kidney disease. And they did a placebo-controlled controlled trial in diabetic CKD with 2 doses of eplerenone. And you can see that with these, you get no change with placebo for albumin creatinine ratio, but a pretty quick and sustained reduction in proteinuria, albuminuria with eplerenone, either 50 or 100. So I consider 50 eplerenone to be roughly equivalent to 25 of spironolactone, so kind of a 2-to-1 ratio, but it may not quite be that potent. Most of the people I'm using eplerenone in, I'm using closer to 100, and a lot of people I would like to use higher, but the pharmacy keeps preventing me from doing that. So GFR similarly declines, just like we saw previously. There's no error bars here because the original publication didn't have that, so I couldn't put that on there. So I can't comment on how much error there, deviation there is. But with eplerenone, same thing we saw with spironolactone. It decreases GFR acutely. All right, there's other studies with eplerenone that also are convincing as far as albuminuria. But just like spironolactone, there are no studies that show prevention of CKD progression to ESRD or for doubling of creatinine or some of the more traditional kidney outcomes. So that's where I think finerenone kind of holds the edge or at least has the evidence. So finerenone is the nonsteroidal MR antagonist. And in their pilot studies, I'm not going to show any of their studies that they did with heart failure, but as they looked in other indications, so diabetic kidney disease, they showed as they kind of tried to figure out what dose to use that these higher doses, 7.5, 10, 15, 20, that they reduced, this is a modeled urine albumin creatinine ratio. So albuminuria, decreased albuminuria in these people with diabetic CKD. So that at the higher doses, 10 to 20 milligrams, I think you can clearly see that there's a decrease. And this is placebo-adjusted reduction in albuminuria. So again, this is not a real hard endpoint, but a surrogate endpoint. And in the early studies, they were not looking at blood pressure. They were not even really looking at the proteinuria. But I'm showing some of these because we're interested in, number one, change in blood pressure. How good of a blood pressure medicine is it going to be? And I think the verdict's still out on that because a lot of these heart failure patients don't have pronounced hypertension. So it's hard to reduce normal blood pressure. So I think you have to take this with a grain of salt, although they did a comparator group with spironolactone, 25 and 50 milligrams. And you can see that spironolactone did reduce blood pressure a lot in the same population, in the same study. So you do have some blood pressure reduction in this population with spironolactone that you're not getting with equivalent doses of finerenone. And the bigger question, I think, in a lot of our patients with diabetic CKD, personally, I have a resistant hypertension clinic, so I'm definitely interested in reducing blood pressure. But I'm just as interested in not increasing potassium quite as much. So this comparator group is kind of useful to see, okay, well, how much does finerenone increase potassium in this kind of higher risk population for hyperkalemia? And it increases potassium. So a lot of the early literature or kind of talk from the finerenone drug development was that it doesn't cause as much hyperkalemia, but it does increase potassium. So you can't just take that and run with it. You can't just think you can put people on this and not change potassium. It increases potassium. So especially at 10 milligrams or 5 milligrams twice a day, you see an increase at 4 weeks and visit 6 and 7. You see an increase in potassium. And it even, not quite, but it approaches the increase in potassium that you'd see with spironolactone 25 or 50 milligrams a day. So we, as nephrologists, we work around this. This is what we do. So this is something to be aware of. Don't think that just because you couldn't use spironolactone in this patient because of hyperkalemia, you're going to be okay with finerenone. In the people that I've done that, I've had issues with spironolactone. I thought, well, this person really needs an MR antagonist. I'm going to use finerenone. At least a couple of times I've done that. I've also had issues with potassium in that same patient. So it probably predicts future failure, I guess, with an MR antagonist. And the same thing with GFR. So this almost parallels the change in potassium or blood pressure, whichever one you want to attribute it to. So the finerenone, again, drops GFR acutely, maybe not quite as much as the spironolactone. That's okay. We know that that's what we're going to see with these beneficial drugs for CKD. So we do see that with finerenone as well. And those are all the preliminary studies before we get into the real studies. So Fidelio DKD, which looked at people with diabetic CKD. So this is the population: diabetic chronic kidney disease, persistent albuminuria greater than 30. So this is kind of low-grade albuminuria, but definite persistent on maximal tolerated ACE inhibitor. And they randomized people to 10 to 20 milligrams of finerenone or placebo. And the outcome of this study was really a death, decreased GFR greater than 40%, or kidney failure. So this is a harder kidney endpoint study. And finerenone did decrease the risk here. So about an 18 to 20 point reduction in the primary composite outcome. So a little bit of an effect, significant effect. It's not, there's still a lot of residual disease progression here. So we need multiple things to prevent that. And this is just all the outcomes. So here's the kidney failure outcome. So this is sustained decrease in GFR on the left. It looks about the same as the primary. Kidney failure, maybe a little bit less impressive. And then the secondary composite, which is kidney failure, sustained decrease of 57%, or death from renal causes, there's a sustained decrease. So it is beneficial to these patients, but it's not, it's not going to prevent everybody from progressing to kidney failure. And the cardiovascular safety is good for these drugs. It also reduces cardiovascular outcomes. I'm just going to show a couple here. One is atrial fibrillation, so they had less atrial fibrillation. Some other studies with spironolactone have suggested some of these same benefits as well, which I'm not showing here, but finerenone also has that benefit. And then the next study that was published by the Bayer group, which developed finerenone, is the Figaro DKD study. So these people had a little bit more pronounced GFR. So albuminuria greater than 300 to 500, but also with pretty normal GFR. And they did the same clinical trial design, looked at the cardiovascular outcomes in these people, because that's, no matter how you cut it, the number one risk to our patients, my patients at least, is cardiovascular. Most of my patients are not going to live to go on to end-stage renal disease. So it's really hard to get the patients to understand that. Also hard for cardiologists to understand that sometimes too. And arguing with the cardiologist that creatinine went from 2.5 to 3 is not as big a deal as they think. You should continue these drugs because the cardiovascular benefit that they get from them is worth it. So cardiovascular death, non-fatal MI, stroke, and heart failure hospitalization was reduced as the primary outcome in this study here. So the bottom figure is the y-axis going to 100. If you zoom in, that's kind of where you see the benefit magnified a little bit. So again, not 100% reduction, obviously, but it does show some benefit, about 12 to, this is 13% reduction. And I think the one outcome, if you do hypertension trials, the two things I tell my patients I'm preventing, number one is hemorrhagic stroke, number two is heart failure. I don't even tell them that I'm going to prevent diabetic kidney disease progression or kidney disease progression, because I'm not really sure that that's proven. But heart failure in these studies is definitely reduced. So you have the reduction of heart failure in patients with diabetic kidney disease, and that's a huge issue in these patients. All right, so hopefully those studies have shown that you do have some cardiovascular and kidney disease benefit in patients with diabetic kidney disease. And that's really the primary data that I'm going to show you with finerenone and newer drugs. And I'm going to just close with a few more slides, and I might fly through a few of them because you already know some of this stuff. Hyperkalemia is bad. People with lower GFR, higher risk for it. It also predicts mortality. And the one thing I'll kind of emphasize on these slides is that the risk is actually greater at low potassium than it is with higher potassium. So we worry all the time about high potassium because that's what we deal with. The cardiologists worry about the low potassium because they focus on the arrhythmias and want to get potassium above 4 and all that. So it is a bigger risk for potassium to be low. But anyway, I'm not going to go too much in that. This paper goes through the hyperkalemia risk. So Rajiv Agarwal and Jason last year. So finerenone does have an increased risk. They looked at it several ways, at potassium greater than 5.5 or potassium greater than 6 or hospitalization for hyperkalemia. And no matter how you cut it, finerenone does have an increased risk above placebo. I think this is the greater than 5.5 figure, but I'm sorry, I might be wrong about that. And they looked at predictors of what causes the hyperkalemia, and it's things that you would normally think would predict it. So the lower your starting potassium, and they use 4.1 to 4.5 is kind of the comparator. If it's greater than 4.5 or 5, you have an increased risk of significant hyperkalemia. I think that makes sense. A lower GFR puts you at higher risk. The real interesting thing from this is that if you use a diuretic of any sort, either a loop or a thiazide, or if you use an Sglt2 inhibitor, you're protected from the hyperkalemia risk. And I think more people know about this now, especially with everybody knew about this with thiazides. And I think everybody now knows about it with Sglt2 inhibitors. They seem to prevent everything. And this is certainly true. So anybody, I can't use an MR. I try to use these things before I ever start an MR antagonist. I want them to be on a thiazide diuretic at a pretty good dose. And that's one of the reasons I use, the NEPJC the other night was about chlorthalidone versus hydrochlorothiazide. And I argue that I use chlorthalidone as much for potassium reduction as I do for blood pressure reduction, because I know that I'm going to need to use Spironolactone. So I'm kind of hoping that chlorthalidone, when I start it, drops potassium from 4.7 to 3.9. That would be great, because then I'm much more comfortable using an MR antagonist. So, and I know that I'm going to, in my patients, I've got plenty of blood pressure to work with. I'm not worried about bottoming their blood pressure out. But you might have that situation where you have to worry about that. So this is from the studies that I compiled at the time, the risk of hyperkalemia, either 5.5. So finerenone, 21% of the people had a potassium over 5.5. So I think that Bayer has quit saying finerenone does not cause any increase in potassium, because as they've gotten further into development, they realize that we just can't say that with a straight face. So it does cause it, less than probably spironolactone, but you definitely cannot ignore it. You have to monitor, you have to mitigate it. So greater than 6, which is really, as nephrologists, what I think you probably get more concerned if it's over 6. And the cardiologists are going to be, really nervous at 5.1, but nephrologists are going to really start taking it seriously when it's 5.7 or closer to 6. So it does increase it, but it's not super common. 4.5% is still a lot of people within, a year of using the drug. hospitalization for hyperkalemia or discontinuation is less common. So usually you can mitigate this and restart the drug. So again, I think you guys know how to do this. The other studies by David Gerlink that I want to highlight is the risk of using an MR antagonist with other drugs. So if you use an ACE inhibitor with a-sparing diuretic, so this includes, amiloride, triamterene, or any of the MR antagonists, your risk of hyperkalemia hospitalization is dramatically increased. So take this into all of our patients are in this category. So this increases the risk tremendously. And Finerone was not around when he did this study. So the next one is Bactrim. We call it Bactrim. I don't know what it is in Canada, but trimethoprim sulfamethoxazole. And this was an issue maybe even more back in 1993 when we used high-dose Bactrim to treat PCP pneumonia in AIDS patients. So they used super high dose, much higher than what I'm used to seeing for just a UTI. But even a UTI treatment dose of Bactrim will increase potassium. So it's a 6.7 fold risk of hospitalization. And if you use it with Spironolactone, it also increases that risk. So the combined use of these drugs is difficult to prevent because, I saw a patient last week, their urologist gave them Bactrim for a UTI, not even thinking about that they're on Spironolactone and an ACE inhibitor. Potassium went up to 5.7, which is okay, but luckily it didn't go higher. So how do you mitigate this and preserve? You want to still use these drugs. So like I said before, I always start a thiazide or a loop diuretic. And nowadays I would start the Sglt2 inhibitor first with the plan of monitoring potassium and then starting an MR antagonist. Monitor them closely, more closely than you might otherwise. And I think Swapnil's argued that dietary potassium education or reduction doesn't make a difference, but I believe it does, especially in those people that have a summer garden and they eat, 5 tomatoes in the summer. It makes a difference in some of those people. So you have to make sure they're educated. Stop these drugs. Addition of bicarbonate. I've done this. I've tried to lower potassium that way with kind of mixed success. But the potassium binders definitely, if you really are in a situation, those potassium binders really do work and make a difference. All right, and the last few slides, I'm going to start zipping a little bit. So instead of metformin, a lot of our patients are going to use with GLP-1 agonist or Sglt2 inhibitors. So the next question is going to be, are these drugs, is MR antagonism still beneficial in people who are on these drugs? And the short answer is yes. It looks like it at least continues to have a benefit. Probably has, so that means that it has an additional additive benefit in these populations. So this is a subset of the people in the study that were on a GLP-1 agonist. You still saw a reduction in proteinuria in those people with a GLP-1 drug. And I'll skip through that. You see something similar with DAPA. So you also get a reduction in GFR. And I'm going to, like I said, skip through these. But there's actually more studies that are coming out with, I think we're more concerned about the Sglt2, or we're more interested in Sglt2 inhibitor and MR antagonist. Do you get an additional benefit with the two? And I think there will be better studies coming out in the near future to answer that, probably in the next 2 or 3 years. But that's the biggest question. And I think the answer, I'm going to predict the answer is going to be you get additional benefit with Sglt2 inhibitors. So it's an additive benefit. All right, so MRAs of all types reduce proteinuria in diabetic kidney disease. Finerone has been shown, and really this is what I give Bayer, who developed Finerone, credit for actually doing a hard outcome study in diabetic kidney disease, because a lot of people have just avoided that. I would say the developers of Eplerenone just kind of said, oh, I don't think we can tackle that. So they have shown that this drug class is beneficial in diabetic kidney disease for kidney disease outcomes, but also cardiovascular outcomes. You do still have hyperkalemia risk that you've got to mitigate in people on an MRA, including finerenone. And like I said, the last group of studies to be done is SGLT2 and GLP-1 agonist. All right, and I will thank you guys for your attention and be happy to discuss any questions that you have.
Thanks, Matt, for that wonderful overview. So if people have questions, please raise your hand in Teams and unmute yourself. But I'll start. I have many questions, but I'll let others also ask. So what do you think about, you showed that MR antagonism reduces proteinuria and blood pressure, even before finerenone showed the hard outcome data. Do you use eplerenone or maybe even amiloride in diabetic kidney disease, or what do you think about using them, even though the hard outcome trials have not been done, just like a poor man's version of using these drugs?
I use, so my approach in general is resistant hypertension. So almost all these people have resistant hypertension. And I consider that Spironolactone has abundant evidence that it reduces blood pressure the best of any medicine as the fourth line agent. And even you can take away some drugs once you do add it. So I use it for resistant hypertension in these patients and then assess proteinuria. And I do think it's very potent. I extrapolate a little bit, to be honest with you, for the proteinuria reduction. So I use spironolactone a lot in people with diabetic kidney disease, but primarily for the indication of resistant hypertension. I don't use as much amiloride for proteinuria reduction. I haven't even really, that's a really good question because I haven't thought extensively and I didn't summarize the literature on that at all here. So that's a good question to think about. I use amiloride in a lot of people for resistant hypertension. I don't think about it as much for diabetic kidney disease. The other, I didn't mention this, but of all the diuretics, the MR antagonists, spironolactone and eplerenone, are really the only ones that don't have to be directly secreted into the tubular luminum. So you get more of a basolateral diffusion into the cells. So it's not quite the same reduction in effect with GFR, but amiloride you do. So I think I predict amiloride might be a little bit less effective at lower GFR for that reason. Did I answer the question?
Yeah, sounds good. Greg Hundemer.
Yeah, great talk, Matt. Thanks so much for the talk today. My question was about, you probably know some of the work on, and especially in hyperaldosteronism, of using renin targets when we adjust MR antagonists. Mm-hmm. Do you feel like there's any role with that in just kind of the broader term of like resistant hypertension, and even like when you use these medications in CKD, is there any role in your mind for following renin levels in those situations?
I do it. So I do use renin as a target for MR antagonism. I don't know that that's standard, but I think for all the people that are hypertension specialists that follow the primary aldo literature, we try to do that. It's really hard in some people, and that's why even in people with spironolactone, I have a hard time increasing renin in some of these people. So it just doesn't seem to increase. So it is difficult, but I do use it as a drug target to monitor that. And I think we need probably more prospective studies for that, but I do believe that in general. And thank you for that. Greg has obviously done that study with Anand Vaidya, and I work with Anand as well, and I think it's a great finding. And it makes the most important thing is it makes physiologic sense. I think it's a physiologic target.
There's a question from the conference room.
There is, Swapnil, there's also a couple of questions in the chat, but Peter, go ahead.
Back to the spironolactone versus these newer drugs, and clearly I think I would only consider using them if the anti-androgen effect is limiting your use of spironolactone. I was interested in the dose equivalence. Anytime you get a new class of drugs, everybody says, well, this one's worth 2 of that one, and it all seems to be a guess. And looking at all those comparisons you showed with respect to blood pressure and potassium increase, it sort of looked to me like spironolactone was maybe just more potent, and maybe the dose of phenerenone you were talking about wasn't the same, and maybe it takes 20 or 40 milligrams of phenerenone to be the same as 50 of spironolactone. Might that be the case?
I think that might be the case. And I think initially when they were developing this drug, they were looking for a niche. And the approach that they were looking for, and I don't know the inner workings of their thinking, but they knew that potassium was an issue, and I think that that's what they wanted to find, the sweet spot for a beneficial drug that didn't increase potassium. And I actually generally agree with what you're saying. I think spironolactone is more potent. It's more potent than a eplerenone. I mean, I have trouble, if people don't tolerate spironolactone, I have trouble achieving the same benefit with a eplerenone that I see with spironolactone. It is hard to beat spironolactone. So I think the next question is, what do you think about spironolactone versus phenerenone? What would it show? I think it would require a dose escalation to try to reach the equivalent either blood pressure or potassium effect of spironolactone to see if you get a better same benefit. But I do generally believe that, but it's not proven. I think that's just a thought experiment.
Yeah, and we may never get that, ideal phenerenone to spironolactone trial that David and many others have been asking for. Jan has a question in the chat about how much do you think the benefits we are seeing is from the blood pressure improvement versus, the actual effect on the aldo?
That's a good question. I do think a lot of the benefit is through blood pressure reduction, especially with spironolactone. You get a lot of blood pressure reduction. I think some of the proteinuria that reduces within the first 2 weeks is really, it's before you get the maximum blood pressure reduction with spironolactone. It takes 6 to 8 weeks to get maximal blood pressure reduction with spironolactone. So I think seeing a proteinuria reduction within a couple of weeks argues a little bit that it's doing more than just through blood pressure reduction. But I think a big issue is with blood pressure reduction. A big benefit is with blood pressure reduction.
And I know it's almost 9, but I'll slip in one more question if you have time. Is that what's your take on these? I know you have been also part of the development, but what's your take on the new aldosterone synthase inhibitors? I know nothing is approved and the trials are still being done, but what do you see? What does your crystal ball say about their utility for us?
So obviously I'm involved in that. So I don't have a financial conflict to make a lot of money on it, but I think clinically I really want to have these drugs in our armamentarium, because I've got a lot of people that either don't tolerate spironolactone for those side effects, and I need the blood pressure benefit, and it's a specific target for a lot of the people I deal with that have either bilateral hyperplasia or primary aldo that we just can't treat real effectively. It would be a lot easier to block aldosterone production than to drive up spironolactone dose to 200 milligrams a day, which we're inevitably going to get these side effects. So a lot of those patients with hyperplasia, which is about 50% of the people, you have difficulty because the adrenal just makes more aldo. You go up on the spironolactone dose, it just in response, it sometimes makes more aldo. And using an aldo synthase inhibitor makes a lot of sense. It also would give us another drug in the armamentarium of blood pressure reduction for resistant hypertension or for multiple drug hypertension. And if that's your population, it's a more specific approach than with spironolactone. And it still leaves the MR open for some activity. So the initial hope, we'll have to see what the studies show, is that maybe you don't run into quite as much issues with hyperkalemia. You will have some issues, I'm sure, but you do have the availability of the MR for some activity. So you can still have some potassium excretion. And if you use one of them that has a shorter half-life, you've got maybe half the day that you're maximally blocking, and half the day you can actually excrete some more potassium. So there's a lot of different thoughts behind these drugs, and I do hope that we have success getting them to the market.
Fantastic. Thanks for the wonderful talk again and the Q&A. Hope I know you were possibly coming to Ottawa a few months ago, but hopefully it will happen in for real the next time.
Yes. Hopefully the airlines there don't just collapse like they did on the day that I was supposed to travel. All right. Thank you, Swapnil, for the invite, and I appreciate your attention today.
Thank you.
And I hope the Aldo conference in Chicago in, I believe it's June. So maybe I'll send Swap some information about that. But I should hopefully at least see Greg there.
For sure. Thank you.
All right.